All right, good morning, everyone. Good afternoon, depending where you are. My name is Tohouri Taylor. It's great to be here with you today. I joined D4I just recently as the project associate director. Today's webinar, led by Drs. Rahim Kebe and Romain Tohouri from JSI, will explore the integration of human and zoonotic data in the One Health surveillance system in Burkina Faso. Before we start, I'd like to say just a little bit about D4I for those who may be less familiar with it. As many of you already know, D4I is a USAID supported project. It works to help generate strong evidence for program and policy decision making, strengthen individual and organizational capacity for data related work, and enhance data use in countries around the world. For more information, please visit the project's website and our social media pages. Today's webinar is actually the fourth in a series focused on the theme of integration in global health. The last webinar in the series just last month explored the integration of machine learning models with electronic medical records through Kenya's Health Management Information Systems project. We have one more webinar scheduled in this series, scheduled for later this summer, and the topic is still being determined, but will be announced soon. Please hold your response to questions until the end of the presentation, but type questions in the Q&A box as they occur to you. Don't use the chat box, use the Q&A box, but feel free to introduce yourself in the chat. Now I'd like to introduce today's presenters. Dr. Rahim Kebe is the resident advisor for the Country Health Information Systems and Data Use Program in Burkina Faso. He is a specialist in public health and management of health systems. Currently resident advisor for CHISU in Burkina Faso, he was previously the director of measure evaluation in Guinea and Burkina Faso. Dr. Rahim has experience strengthening routine health information system and disease surveillance systems. He's coordinated the implementation of electronic data management tools and other tools for data quality. He's an expert on the One Health approach. Dr. Romain Tohouri is an expert in the field of health informatics and ICTs for development. He has over 16 years of experience designing and developing health information technology for lower and middle income countries. He worked from 2016 to 2010 as a DHIS2 expert implementer for the University of Oslo and is now part of JSI's Center for Digital Health. He led and developed national HIS assessments, HIS enterprise architecture, and national level HIS implementation like the One Health project. Drs. Kebe and Tohouri, thank you and welcome.
Thank you.
Thank you.
Okay, can you see my screen?
Yes, it's good for me.
Okay, so Dr. Kebe, I think you can go ahead with the presentation.
Need to put it in slideshow.
Can you see the slide?
Okay, thank you.
Oh, okay.
Yes.
Perfect.
Okay, perfect. Thank you. I'm Rahim Kebe, the resident advisor of CHISU in Burkina Faso. CHISU stands for Country Health Information System and Data Use Program. It is a pleasure to share this experience of disease surveillance using the One Health approach in Burkina. This approach has proved to be an important tool in multisectoral collaboration. For that reason, I have decided to focus my presentation on the successes and opportunities that it presents for the response to epidemic diseases. Next, please. Yeah. My presentation is divided in 5 parts. First, I will start with introducing the topic. And second, I will present the context of the One Health approach specific to Burkina Faso. Third, I will talk about the CHISU project, its objectives, its area of intervention, and the main results achieved. The fourth part will raise the challenges to overcome in order to make the approach better. And finally, I will summarize the presentation. Let's go next, please. Just as introduction, CHISU project is founded by USAID with a view to strengthen the health information system in Burkina, and especially the disease surveillance system using the One Health approach. Burkina Faso, like most West African country, is in the process of implementing the multisectoral approach to fight against major epidemics in accordance with the recommendation of the Global Health Security Agenda, GHSA, adopted in 2014. The Ebola epidemic, which occurred in 2014 in Guinea, Sierra Leone, and Liberia, significantly reinforced the understanding of the role of zoonosis in the occurrence of human diseases, and especially the need to see the human health in a global way, considering the correlation with its environment. As you could see in the slide, on the slide, scientists attribute 60% of infectious animal diseases and 75% of emerging diseases to zoonosis, so to animal origin. This situation has led countries to adopt the multisectoral approach with which take into account human health, animal sector health, and in interaction with the environment. So One Health information system was launched in Burkina Faso to create a comprehensive and effective response to zoonotic and key human health. The CHISU project has been involved in this process with USAID funding in order to strengthen the disease surveillance system by supporting the stakeholders, organization, and providing actors with tools to share information among different sectors. Next, please. The health context of Burkina Faso is similar to most West African countries and has remained very marked by the occurrence or even the resurgence of epidemics throughout the regions. As I mentioned it earlier, the occurrence of the Ebola epidemic in West Africa significantly affected mentalities and approach. And this has reinforced the idea of organizing the surveillance system in a more integrated way, involving other sectors besides the human health sector. This implies multisectoral collaboration, having common tools for managing situation and to conduct joint investigation for decision-making. So in Burkina, 3 ministries, namely the Ministry of Health, the Ministry of Human Resources, and the Ministry of Environment, have been associated with the One Health approach. Before adopting this approach of One Health, each ministry had its own monitoring system, and there was no formal mechanism for sharing data among the 3 ministries. And in addition, there was no electronic data management system in any of the 3 ministries. Next, please. So since 2017, Important action have been taken by the government of Burkina Faso to prevent diseases. They have initially defined 5 priority zoonoses, which will be jointly monitored by the 3 One Health ministries. The 5 priority zoonoses are anthrax, rabies, highly pathogenic avian influenza, brucellosis, and dengue. So in terms of governance and leadership, as you can see on your right, significant action have also been taken to set up new organizational charts that will enable the coordination on the One Health approach in the country. The organizational chart is made of 3 tiers of bodies. The first tier is the National One Health Council, chaired by the Prime Minister. The council meets twice a year. It is the supreme body of the coordination committee. The second tier is the technical secretariat, which is responsible for managing the operations of the last tier, comprising 3 bodies. The last tier is made up of the representative of the different ministries organized in 3 bodies. The first bodies comprise the local points of different ministries. The second body is constituted of 7 thematic commissions, which represents, let's say, based on the recommendation of the Global Health Security Agenda. To illustrate, we have the Zoonosis Commission, the Surveillance Commission, we have the Antimicrobial Resistance Commission, etc. And the last body of the last tier is the One Health Committee at the regional level. But for, let's say, for political reason, this tier is not functioning right now. So CHISU supports the holding of the National One Health Council, which allows important decisions to be taken in order to strengthen the functioning of the One Health coordination bodies, such as approving pending decisions or signing of conventions. So the last interministerial council was held on January 21st of this year. Next, please. The main objectives of the CHISU project are to strengthen the disease surveillance system in Burkina through the use of the One Health approach. Again, to strengthen the availability of high quality health data at all levels of the system. The other objective is also to increase multisectoral coordination, the capacity to manage the surveillance information system to respond to major epidemics, and also to improve the central level on decision-making and swift reactions to epidemic. Next, please. So as our domains of intervention, CHISU has been supporting Burkina Faso since October 2021 in the area of surveillance, routine information system, and also in the response to COVID-19. These are activities that had already been initiated by major evaluation, which ended in 2020 under funding of USAID. In the specific area of disease surveillance, CHISU supports the Global Health Security Agenda recommendations, especially in the area of prevention and response to epidemics. The main activity are therefore zoonotic diseases, real-time surveillance, reporting, and multisectoral response to to epidemics. Next, please. So as a result, first, in the domain of governance and leadership, the One Health Coordination Committee meets regularly with the support of CHISU and other USAID implementing partners. For example, the National One Health Council held its last meeting on January 21st this year, one day before the coup d'etat. 3 ministers attended that meeting, and important decisions were made in that meeting. Next, please. So the process of implementation involved the 3 ministries, the Ministry of Health, the Ministry of Animal Resources, and the Ministry of Environment, as well as a number of other partners. So the key actors are from the technical directorates for surveillance in the 3 ministries, the IT directorates in the 3 ministries. We involve also the laboratory from all the 3 ministries, as well as other stakeholders. So this means that the approach used by CHISU is participatory, even if the actors come from 3 different ministries. Despite all this, there are still some challenges to overcome in collaboration with people from different sectors. Next, please. This graph shows the architecture of the One Health electronic platform. So the collaboration among different sectors has made it possible to create this architecture of system. As you see on your left, 4 DHIS2 surveillance databases have been set up, taking into account 3 steps. At the first stage, each ministry managed independently its own database in data collection, in data analysis, and even in management of its own information flow cycle. At the second stage, data from each ministry are sent to the One Health database through the interoperability layer as aggregated data. And the last stage, information from the One Health database are sent to stakeholders in text or email for decision making. So for the first time, information on human and zoonotic data have been integrated and linked to the information system of the Ministry of Health, to the Ministry of Animal Resources, and also to the Ministry of Environment. Next, please. This slide shows the circuit of information with the One Health approach, starting from the community level to the central level through the intermediate levels. So first, here on the left, community agents identify initial event through tool called image boxes. In French, we say boîte à images. So there are 11 possible events that relate to the diseases on surveillance in the 3 ministries. So the nurse will come and at the community level to assess the alert or signal if suspicious sample collection is done. And so FOB is not, the nurse inform this alert. So the data is entered into the electronic platform using a tablet. at the health facility level, or maybe the equivalent according to the ministry concerned. And then information is transmitted according to the circuit of information of each ministry to the central level for decision making. The samples are transmitted to the laboratory, which has also equipment to enter the results. And these results determine the need next, please. Next, please. Okay. This chart presents the dashboards from the 4 databases. As you could see, all diseases under surveillance in the health sector, animal sector, and environment sector are monitored, including priority zoonosis that I mentioned, data, COVID-19 data. Next, please. Next, please. Okay, thank you. And we are also implementing the community-based surveillance system called event-based surveillance, EBS, by training and equipping community workers from the 3 ministries. To date, about 2,000 community workers have been trained in our regions of intervention. We are working in Central West, Boko de Moon, Central South, and Plateau Central. And right now, we are continuing to the training and supervision in other districts. Next, please. The other benefits of this electronic tool is to contribute to the response to the COVID-19 pandemic. So the electronic platform has been adapted to ensure the response to the COVID-19 and allow real-time notifications, access to text results, monitor vaccination data, and even to view supplies data. Next, please. Here you see the interoperability system developed by Measure Evaluation and CHISU. And this system has also become the model and building block for the deployment of other systems and tools needed in the country by the use of the interoperability layer to access and share data among systems. To date, the routine data management system and the surveillance database are fully linked by the interoperability layer. Also, the mHealth for community data is also connected to the routine information system called ANDOS here in Burkina Faso. Thanks to the system, conditions are now set to facilitate exchange of data between systems. Next, please. Okay. I would like to end this part of my presentation on results by sharing with you this experience of multisectoral collaboration in responding to events that could affect health of people, animals, and also the environment. So in July 2021, a significant mortality of fish and cattle was reported in the Boko de Moon region around the river called Mohun. This event gave rise to a joint investigation led by the One Health Technical Secretariat and bringing together actors from the human health sector, the animal sector, and also the environment sector, who visited the site and carried out investigations. It turned out, after laboratory analysis of water samples and dead animals, that the cause was due to the presence of cyanide spilled into the Mohun River by gold panels working in the region. At the end of the investigations, recommendations approved by the 3 ministries were sent to the populations concerned by the event. In the past, this type of events would have been managed separately by the ministries concerned, whereas collaboration could have produced better results. From these lessons learned, it can be concluded that it is possible to make interoperability between people and processes, even from different sectors, in order to obtain effective results in the response to the diseases that affects the world today. And I think the COVID-19 pandemic has reminded us of the need for this multisectoral approach. Next, please. So as you can see on this map as challenges, 4 out of 13 regions are currently covered by the One Health approach through USAID funding. So as challenges, the extension of the use of electronic platform beyond the 4 regions is already a necessity, but this implies more resources in terms of capacity building, in terms of equipment, also in terms of internet connection, etc. There is also the global context of COVID-19 for a country with limited resources like Burkina Faso. The order of priorities can be influenced. Moreover, because of the security context, many areas in Burkina Faso are inaccessible. Next, please. So to summarize my presentation, I can say that multisectoral management of disease surveillance is an approach that is progressing in Burkina Faso. Support from USAID and other partners helped to lay the first foundation of this vision. For the first time, information on human and zoonotic data were integrated and linked to the information system of the 3 ministries. But the challenge of sharing data among actors from different ministries is in the process of being taken up. However, the challenge of using data with this approach for decision-making depends on the effective coverage of the country by the tools put in place, and therefore of the extension. Next, please. I think it is the end. So thank you for your attention. I stay tuned if you have any question. I am with Dr. Romain Tohouri, who could also help to answer your questions. So thank you.
Thank you both so much. And thank you everybody that's contributed questions in the chat. We have plenty of time for Q&A, and we're going to get started in the order that the questions have appeared here. The first question is, how is integration within HMIS and the DHIS2 handled?
Okay. So let me go back to the graphic here. Integration between the HMIS and the One Health. So in Burkina Faso, the HMIS is called ANDOS. That stands for Integrated National Data Warehouse. And that is the database that is handling the HMIS, the Routine Health Information System. So the integration, as you can see here, is on the weekly disease surveillance data. It is called TLO. It stands for Telegram Official Letter. That is normally sent by facility to the district, and from the district to the region, and from the region to the central level, using phone calls to report diseases. So they continue to do so, but as most of these diseases are also collected by the different ministries involved in the One Health, so the same data is also collected in the One Health system as well. So this data is automatically also reported to the ANDOS from the One Health electronic database as well. And so the ANDOS, the HMIS unit can have different sources of this surveillance data and be able to do some triangulation and analysis of the data. So, Dr. Kebe, do you want to add more to it?
No, I agree with what you said. It's okay for me. Thank you.
Thank you both. The next question is, monkeys and bats are also responsible for spreading disease. Why are these animals not seen in the diagrams used for teaching community health workers?
OK, Dr. Kebe, la question c'est de savoir si puisque les singes et les chauves-souris sont responsables aussi des transmissions de zoonoses, la question est de savoir pourquoi est-ce que dans les diagrammes qu'on prend pour former les agents de santé communautaire, pourquoi est-ce que ces animaux ne sont pas représentés aussi? Je vais prendre la question en français ou en anglais, je traduis, que je pourrais compléter.
OK, bon, je peux répondre directement en français, après vous allez traduire. Alors, en fait, les animaux sont pris en compte dans le message qui est attribué qui est envoyé aux agents communautaires pour sensibilisation. En fait, dans le passé, il y avait cette formation communautaire, des agents communautaires qui se faisaient, donc la surveillance à base communautaire, qui était menée par le ministère de la Santé, donc qui véhiculait des messages propres au secteur de la santé. Mais à la différence de l'approche One Health, ce que nous avons pu faire, c'est d'associer les deux autres ministères à celui de la santé. Donc, on a associé le ministère des Ressources animales et le ministère de l'Environnement. Donc, en tenant compte de leurs spécificités aussi. Donc, le langage qui était dans les boîtes à images, je le disais tantôt dans la présentation, les boîtes à images renferment autour de 11 messages. Et ces messages sont relatifs aux animaux aussi. Ce n'est pas seulement, n'est-ce pas, la santé humaine qui est concernée. Donc, on a dû modifier le contenu de la boîte à images pour adapter au contexte One Health. Donc, tenant en compte ce que font les autres ministères. Par exemple, la mortalité des bétails, qui n'était pas prévue par le passé dans la boîte à images, a été introduite dans les nouveaux outils, de même que plusieurs autres événements inhabituels que l'agent communautaire peut reconnaître, n'est-ce pas, dans la communauté. Donc, on a pu synthétiser tout ça pour, n'est-ce pas, mettre à jour la boîte à images. Thank you. Merci.
So in the context of Burkina Faso, there were already existing some community-based, event-based surveillance tools at the Ministry of Health level that included everything related to key disease under surveillance for the Ministry of Health. But in the context of One Health, we had to take into account what other ministries like Ministry of Environment, Ministry of Animal Resources are also doing and collecting and tracking. So this has led to a revised version of the tool that's taking into account the priority zoonotic diseases, but also what other ministries are doing, like death among cattle and over domesticated animal or wildlife, and that's what's led to a revised tool that is kind of taking into account the different the specificities of these ministries. So to come back specifically to the bat and monkeys, I think we don't have the entire booklet, but I think these are also taken into account. I can recall, for instance, an example of one of event that was reported in Burkina Faso in one village that was reported using the One Health system was a very huge number of bats in a village that was reported, and that made what was object of a joint investigation, and it's led to some activities where the investigator talked to the people in the village and gave them advice to not to eat them or come too close to those bats. So these are taken into account, but really with an emphasis with the priority zoonotic diseases selected by the government of Burkina Faso. Over.
Thank you. The next question is about the event-based surveillance approach that you used. How was the event determined, and was there some community participatory process involved?
So how the event is selected and the involvement of a community, right?
I think it means how the event was identified or defined.
Okay. Donc, Dr. Kebe, la question, c'est de savoir, dans le cas des événements à base communautaire, la surveillance à base des événements, comment est-ce que les événements ont été identifiés et puis aussi comment est-ce que ça marche au niveau communautaire?
Oui, en effet, comme je l'ai dit précédemment, les agents communautaires disposent d'outils de communication et de sensibilisation. Ce sont les boîtes à images. C'est-à-dire, c'est, comme vous voyez sur la diapositive qui est là, c'est une illustration des événements inhabituels qui surviennent dans la communauté. Donc, dans le cadre de One Health, donc, cet outil qui était initialement utilisé par le ministère de la Santé a été réadapté dans le contexte One Health. Donc, le travail que nous faisons en tant que projet, c'est en partie donc, dans le système que nous mettons en place. Ce volet surveillance à base communautaire donc, consiste à aller former les ICP, c'est-à-dire les infirmiers chefs de poste, mais aussi l'équivalent des infirmiers des autres secteurs au ministère des Ressources animales et au ministère de l'Environnement. Donc, tous ces trois domaines sont formés dont le rôle sera d'aller former les agents communautaires pour faire passer les messages à la population comment identifier un événement inhabituel qui pourrait avoir une conséquence en termes de santé publique. Une mortalité suspicieuse, par exemple, qui surviendrait dans la communauté, l'agent communautaire ayant sensibilisé la population, dote en tout cas les personnes en capacité pour identifier ces événements afin d'informer qui des droits. Donc, l'information remonte selon le circuit propre à chaque ministère. Mais comme nous sommes dans le cadre de One Health, il arrive qu'il y ait des investigations qui se font au niveau local, qui amènent, n'est-ce pas, les acteurs des 3 secteurs à aller faire des investigations. S'il faut faire des prélèvements et à envoyer au laboratoire concerné. Et ce sont les résultats de ces examens qui vont remonter au niveau central pour qu'il y ait, n'est-ce pas, un déclenchement d'investigation ou en tout cas de prise de décision.
Okay. So,
Merci.
what Dr. Kebe is saying is that the EBS tools are tools that are given to the community health workers as tools for communication and conducting awareness activities in the community. These are called boîtes à images in French, that are picture booklets. And those, as is previously said, those are tools developed by the Ministry of Health that the project adapted to and broadened to take into account all the One Health priorities, zoonotic diseases, and the specificities of the One Health. These two, the way it works is that the project is training, for instance, at the Ministry of Health, the equivalent of the nurse in charge of the health post, and also equivalent of these nurses for the different ministries. So it can be for Ministry of Animal Resources and Fishery, it can be veterinarian auxiliaries, it can be trappers for the Ministry of Environment, and train those persons. And these are in return going to train the community agent for their respective ministries so that they are able to identify any abnormal event happening in the community and report that to their hierarchy. And so what happens is that when there is an event that they identify in the report, there is an investigation that is done by the ministry. And if this is something really serious and concerning, then usually there is a quick interministerial team that is created and that goes to investigate. Usually some of the nurse, health post nurse, and a veterinarian and someone from the Ministry of Environment when needed, and they go and do the investigation. And then if really something it's important, then they report to the district, and there is an investigation team that can come and select everything, do some sampling, send to the labs and everything. And so that's normally the way it goes up to the, and they report in the platform, and the information is carried over to the national level. All right.
Thank you. The next commenter says, I see that the study locations are clustered in the center of the country. I would love to see sites well dispersed or spread. Is there any particular reason for selecting project sites in this manner?
Kebe, donc la question est de savoir qu'on voit que les régions du projet sont centrées un peu dans le centre du pays. Est-ce qu'il y a une raison particulière pour ce que ce soit fait de cette manière? Le participant aurait souhaité voir un peu les choses éparpillées à travers le pays.
Oui, disons, Le choix des régions d'intervention du projet, ce qui a prévalu à ces choix dépend de plusieurs facteurs. D'abord, il fallait tenir compte du contexte ONEV, c'est-à-dire à la fois, on sait que le pays est couvert entièrement par le système de santé, donc il fallait que le ministère de la Santé soit représenté dans la région. Il fallait que les deux autres régions, les deux autres ministères aussi soient représentés dans les régions où nous allons intervenir. Donc, c'est ainsi que dans les 4 régions choisies, il y a par exemple des aires phoniques où des activités sont intenses au niveau, par exemple, du ministère des Ressources animales et aussi du ministère de l'Environnement. Donc, c'est ce qui a prévalu le choix de ces régions d'intervention. Mais au-delà de ça, au Burkina, nous avons aussi le contexte sécuritaire qui est assez précaire, où de façon assez régulière, et même dans nos propres régions d'intervention, il y a encore des menaces sécuritaires qui sont là. Donc, c'est tout cela qui a prévalu au choix de ces 4 régions. Mais nous sommes un projet amené à évoluer. Comme je le disais tantôt, on a commencé par 2 premières régions avec Major Evaluation, qui était le centre-sud et le plateau central. Avec Chissou, nous allons dans 2 nouvelles régions, la Beaucoup de Monde et le centre-ouest. Nous espérons, avec les perspectives qui s'annoncent et les opportunités, et surtout les défis qui restent, c'est-à-dire étendre les activités au-delà de ces 4 régions. Donc, comme je le disais dans les challenges et défis, nous espérons aller au-delà de ces 4 régions.
Okay, so the reason for the choice of this region for the project are several. First is that because it's a One Health project, you want to start with regions where all 3 ministries involved in the approach are present and active. So you want some region where you have, let's say, forests and parks managed by the Ministry of Environment, where we have active presence, and we know for the MOH it's almost everywhere, and also activity where there is important activities for Ministry of Animal and Resources. So that's why the project started with this region, but the project has the ambition to cover the entire country. So, for instance, the project started with 2 regions under major evaluation at Plateau Central and Central West, and now they moved to Boucle du Noum and over Central-West region. So now it moved from 2 to 4 regions, but also there is the aspect of the security. Burkina Faso is a country where we still have some terrorist attacks, and even the region where the project is working, we still see some security issues there. But the project is doing the best to expand as much as possible and expand to the rest of the country.
Thank you. The next question is about training the health workers, and the commenter would like to know how many per capita community health workers or nurses were trained on the tools, and what population each nurse or trainee covers or provides services to.
Oui, Kebe, est-ce qu'on peut avoir le pourcentage un peu des agents de santé qui ont été formés sur ces outils et combien de personnes ces personnes-là aussi ont formé?
De façon, disons, globale, nous avons formé 2000 agents communautaires. donc, c'est un processus qui a évolué depuis ce Major Revelation. Initialement, donc entre 2018 et 2020, on avait formé à peu près 400. Et depuis 2020, donc, enfin depuis 2021 avec Chissou, nous avons pu former autour de 1600. Donc, le tout réuni, ça fait 2000 agents communautaires. Mais le processus est très délicat dans le cadre du One Health. C'est différent d'autres types de formations. Comme nous travaillons avec les agents communautaires et puis avec les 3 secteurs, donc l'approche, elle est vraiment progressive et elle se fait, disons, à petits pas, parce que c'est une formation en cascade. Il faut commencer d'abord par, disons, comme je le disais, une formation de formateurs au niveau central ici, qui vont former à la fois la région et aussi les ICP, les infirmiers chefs, et leur équivalent dans les autres secteurs. Et aussi, à leur tour, ils vont former, n'est-ce pas, les agents communautaires qui vont, à la fin, n'est-ce pas, adresser des sensibilisations auprès de la population. Donc c'est dire qu'au total, on a ces 2000 agents communautaires formés, mais en amont, on a pu couvrir l'ensemble des points de prestation des 4 régions. Nous sommes pratiquement vers la fin de formation. Je n'ai pas le chiffre exact du nombre de personnes formées, mais si vous prenez un district, on forme à la fois au niveau district même, dans le secteur de la santé, on forme au niveau district, et puis on forme les points de prestation, c'est-à-dire les centres de santé, les responsables des centres de santé. Donc, on le fait à la fois pour la santé, on fait pour les ressources animales, on fait pour l'environnement. Donc, comme c'est une formation conjointe qui concerne la surveillance à base communautaire, mais aussi la surveillance basée sur les indicateurs avec la plateforme électronique, on mène une formation conjointe. Donc, c'est à l'issue de cette formation qu'on va au-delà pour former les agents communautaires. Donc, c'est ce qui explique aussi un peu la lenteur du processus, mais le nombre de 2000 agents formés, je crois, semble significatif par rapport à tous les contextes que j'ai évoqués tantôt, l'accessibilité des régions, les conditions sécuritaires et tout ça. Mais c'est un processus qui est dynamique et qui compte évoluer.
Yeah. So currently the work is still in progress, but under major evaluation from 2018 to 2020, we were able to train 400 community health workers, and under Shisu since 2021, the project was able to train 1,600 community health workers. But the process is very sensible. It's not something easy to continue to do, and it's going step by step, because it is a process that involves a cascade training. So we start by training the different ministries of health staff at the central level. Then they do the training for the region level, and then the region staff will go and also train the nurse chief of health post, and then they train the community health workers, and that will also do some awareness activities at the community level. And those training basically are joint training. When they do a training in a region or a district, they will bring people from Ministry of Health, staff from the Ministry of Environment, and staff from the Ministry of Animal Resources. We train them in the event-based surveillance, but also on the use of the electronic platform. And it's after that training that then the community health workers will be trained also by the staff. So it's a really step-by-step process that takes time, But despite the security concerns, the project is still able to continue and to improve on that.
Thank you. Another commenter is interested in knowing how other countries in the region might initiate the introduction of a system like this one.
I'm not sure if I get the question correctly.
The question is, how can countries in the West African region apply for the introduction of the system, which I understand to mean consider starting a system like this locally as well.
Ok. Dr. Kebe, donc la question est de savoir comment est-ce qu'un pays de la sous-région ouest-africaine pourrait commencer à appliquer un système tel que ceci. Voilà. Je crois que la question...
Bon, je pense que de façon peut-être plus stratégique, on sait que pratiquement tous les pays de la sous-région ont été influencés par la survenue de Ebola dans la sous-région. Je crois, je le disais dans la présentation en introduction, que ça a quand même amené les différents pays à reconsidérer leur approche dans la lutte contre les grandes épidémies. Donc, c'est ainsi que pratiquement beaucoup de pays ont bénéficié du financement GSSC, du Global Health Security Agenda, avec l'USAID notamment. Donc, c'est le cas de la Guinée, par exemple, que je connais, mais aussi ici au Burkina Faso. Donc, ces fonds est encore à la disposition de beaucoup d'autres pays. Donc, c'est à travers ces fonds que l'approche multisectorielle One Health est implémentée. Pour cela, bien entendu, il faut qu'il y ait des projets qui en ont l'expérience et l'expertise, surtout. Donc, ça a été le cas sous Major Evaluation et Chisu aussi travaille dans ce sens. Mais je pense que au-delà de tout, c'est l'expression même du besoin de la part du pays qui peut amener, n'est-ce pas, à trouver l'implémentation d'un tel système. Donc, si les acteurs publics, en tout cas au niveau des dirigeants du secteur de la santé ou même, en tout cas, les décideurs, expriment les besoins, je crois que les partenaires, les bailleurs comme l'USAID, plutôt à l'écoute de ces propositions.
Merci, Doctor. So, since Ebola in the West African region, I mean, there is mechanism like GSSA provided by USAID and other funders that help countries implement intervention like this one in Burkina Faso. It's really to the country to express interest, and then organization like Shisu other organization can really help on that. But in the other hand, I can add to what Dr. Kebe just said, that we are trying to be open as much as possible in Shisu and share lesson learned with the community. We are publishing a lot of success stories and documentation around our approach and what we did. And yes, so we'll be happy to share as well.
Thank you. Apologies to those of you whose questions we weren't able to answer. This recording will be posted to the D4I website soon, so if you want to go back and review the slides or hear it again, keep an eye out for that. And everybody, please also keep an eye out for an announcement coming soon about the next webinar in the integration series. Again, thanks so much to our presenters and to everyone else for being here today. We are at the hour, so I'm going to close the webinar. Thanks, everyone. Have a great day, great evening.
Thank you so much.
Thank you, Tohouri.
Take care.
Thank you so much.